I have the privilege of having Dr. Peter Wenger, who was previously a New Jersey Medical School faculty member. Peter is also a graduate of New Jersey Medical School. He completed a residency in Pediatrics International Health at Case Western Reserve in Cleveland. Subsequently, he spent 2 years with the EIS, Epidemic Intelligence Service of the CDC. While Peter was here, he actually rose to the rank of associate professor, and he was known in particular as a very good educator. To the best of my knowledge, he's the only one who was a Golden Apple nominee, which is our highest teaching award, by every class at New Jersey Med School, first, second, third, and fourth year classes. Peter is recognized nationally, okay, but didn't win. Yes, we had to throw that in. But being nominated is a good thing. Peter is recognized both nationally and internationally for his expertise in child immunization and vaccination. Currently, he is working at St. Peter's University Hospital in pediatric infectious diseases. It's my pleasure to have Peter Wenger join us today.
Well, thank you.
Peter, this is for the remote people, so you have to hang it someplace and put it in your pocket.
Oh, boy.
That's okay?
Yes. Well, welcome, friends. Right. So, obviously, I'd given this before, so please bear with me. I didn't rewrite the whole thing, but essentially reviewing it isn't always the worst thing in the world. And so I called it an influenza, and somebody passed me in the hall and said, by the way, that's the worst pun I ever heard. So I said, but it's taken from a chant that was very popular in the United States or Europe in 1918, and it was, I had a little bird, his name was Enza, I opened the window, and influenza. Now remember, in 1918, they weren't sure what was causing. The influenza virus was actually isolated in 1933, so some 16 years after the 15 years after the epidemic. And initially, I think I mentioned this the last time, the first agent they thought was responsible was a bug that they called Pfeiffer's bacillus, which was isolated in the lungs of the first few soldiers, American soldiers, who died of influenza. And Pfeiffer's bacillus from that time is now known as Haemophilus influenza, the bug Haemophilus influenza, and that's where it got its name from, because it was initially thought to be the agent responsible for the flu epidemic. Okay, and this was a picture. I'm sure Dr. Evans, our historian here, and Dr. Evans is actually in the picture. And these are troops in Seattle headed off to World War I. Right? And if you can notice, they're all wearing what was then the epitome of protection, a surgical mask. So the armed forces, they all had to wear this. And in fact, the mortality nearly matched the mortality of World War I, the mortality to the flu. And at that time, most of three-quarters the flu mortality happened between September of 1918 and Christmas of 1918. So it was over 500,000 people in the United States, and worldwide it was considered 40 to 100 million people. So could you imagine and this is a much smaller population than we're talking about now, the impact on the healthcare services all over the world, where, I mean, people were still having heart attacks and, the other stuff, and there was a war going on. And now you have superimposed on this other epidemic. So it's quite striking, obviously. And it didn't only apply to the military. This is our pastime, which we're starting. Today's the second day of spring. This is a baseball game. And you notice the players had to wear. This was the protection. And there were many cities and municipalities throughout the United States that required you, if you were going to walk outside, to wear surgical masks. And you could see the people in the audience are also wearing it. I used to catch. It must have been hell on a catcher. It's hard enough catching to have the mask and the surgical mask. And this is a picture from Camp Funiston, which was one of the training camps for the American troops, for the expeditionary force that eventually ended up in Europe. And it's actually now felt that this is where the 1918 epidemic arose. It was near farms. It was near pig farms in Kansas. The soldiers came. They congregated. The new virus, the pandemic virus, originated there and spread. So people, and then, of course, sending troops with this infection all around the world didn't help matters any. Okay. And this is a sort of an amazing chart. This is life expectancy in the U.S. And you can see it's going up, 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 except for 1918, when there's a huge drop. And that was due to the flu, because if you look at 1940 or 1941 through 1945, there's no corresponding drop, despite World War II. But it's that flu epidemic, and because probably so many babies died during that time that it really affected the life expectancy. And they figured the masks weren't enough, so they incorporated gargling. That's a really cute picture, right? Right? So how to avoid influenza? Gargle daily. And I'm not sure it was such a great idea for school children with influenza to gargle and spit at school, but they had no idea what was going on. So they were sort of desperate. So that was our preventive measures in 1918, so probably the worst, maybe HIV certainly could be up, but it's in a short period of time, one of the worst natural disasters in the history of at least recorded history of humankind. So what is influenza? Influenza is an acute febrile respiratory disease. And it's marked, the general is seasonal flu, by an abrupt onset of fever, malaise, and myalgia, followed by respiratory symptoms. So for you clinicians there, the kid coming in who's been sniffling for a week, it's probably another respiratory infection, not influenza. Influenza is the classic influenza. And that's the patient that I felt fine, I ate lunch, and suddenly I felt like I got hit by a truck, and I got a fever. What's going on? And then later, the next day or so, you'll see the develop respiratory symptoms. So that's a classic. It lasts generally 5 to 7 days. It's spread. If you read the books, and I just had an argument in the infection control in the hospital on that, because they only have droplet precautions. And if you look, that's the recommendation. I think you should have droplet nuclei and contact, but that's not what's recommended, and I'm not sure why. Incubation period is 1 to 4 days. Average is 2 days. Now, this is interesting. Adults shed the virus typically from 1 day before they become ill through 5 days after onset of symptoms. Children shed normally more and longer than adults, with a range from 6 days before they become ill to up to 2 weeks afterwards. Now, good, successful, except for smallpox, successful infectious diseases spread best when you're asymptomatic. For instance, I don't know that Fatima doesn't have the flu or won't have it tomorrow. So she could be, and I'm sorry to pick on you, but you're sitting in front of me, but you could be spreading it like what? Nobody knows. You look fine. And that's how it spreads successfully. If you're sick and you got snot running out of your nose and you look like crap and you got a fever, usually you stay at home, which is sort of a self-imposed isolation. Or if you do mistakenly go outside, people take one look at you and keep away. Right? But if you look fine, that's when it spreads. And kids can do it for several days before they become sick and after they recover. So it's actually children, and as us pediatricians, in the room. No, it's children that are the driving force, or the epiforce behind influenza. And it usually goes in yearly cycles. In temperate climates, you see mostly late fall through the winter. But it can change, as I'll show you. This is clinical manifestations by age group. Again, you know it's fever, myalgia, respiratory, generally a sore throat. But there's two things I want to point out. In children, you often see nausea, vomiting, and occasionally diarrhea. In adults, you almost never see that with flu. So always this thing, oh, I've got the stomach flu, is probably not the flu. And by the way, we perpetrated, that's the worst thing to call. If you get sick between October and April, and you go to your doctor, if it's respiratory or anything, they go, you got the flu. And the flu has become a term to connotate, or to suggest, well, to connotate any respiratory disease, or actually anything. You know, you could have the 24-hour flu, you could have the blue flu, you know, you could have the stomach flu, but they're not. But using that terminology has hurt us, because what's happened is that when you get the flu vaccine, and then going forward, and you say, oh, and then you come in 2 weeks later, 6 weeks later, and you've got something, oh, you got the flu. Oh, there, the flu shot doesn't work. But in fact, you probably don't have the flu. There's a lot of respiratory viruses that mimic the flu. But our terminology and our speaking to patients, so be very careful. I never say that to a person. If they call, I would say, oh, you have a respiratory infection or something, but I don't say you have the flu. But notice, so kids will have, especially the younger you are, abdominal complaints with diarrhea and vomiting. The other thing that's important is look at the elderly and fever. And this affects assisted living centers, where they could have outbreaks of flu and not recognize it because there's no fever in the patient. You always think of it as a febrile respiratory disease. But in fact, it can spread and has through assisted living centers and so forth in elderly patients where they show up without fever. So those are two important issues to remember with the flu. And the complications, it's not only the flu in itself and why it affects the elderly so great, it'll cause exacerbations of cardiovascular disease, diabetes, asthma, cystic fibrosis in both adults and children. It can cause encephalopathy as a complication that we see. That it's more often seen in Asia than it is here, but certainly you can see, we see it occasionally myocarditis. I just had a patient with myocarditis from influenza. But the big problem is it exacerbates underlying conditions, which is why it has such a profound effect, especially in a group that's over 60, 65 and older, which I didn't think I'd ever say I have now joined. Much to my shock. You know, I was one of those 60 guys. I'm not going over 40. Well, now I'm hoping to get to 90, right? So what? There's plenty of systems. After 1918, the United States became the world became very acutely aware of flu, and there's numerous, we won't go through them all, but there's numerous influenza surveillance systems. I'm sure you've heard the term influenza-like illness. There's surveillance for all these things and trying to gauge what the season, and try to anticipate future pandemics. Probably the most famous, and the one that you can see most often, is the 122 cities mortality reporting system, which is pneumonia and influenza. And you'll find it in the MMWR. Everybody knows the MMWR. You'll find it every week. The back, it's a part. And it has been for a year, 70, 80 years? It's been there for 70 years. It's been there as long as the MMWR has been there. And the 122 cities is a historical reference. Those are the cities that were most, because if you look at it, you go, why did they pick like Elizabeth, New Jersey in it? And you'll see New Jersey is very overrepresented, right? And when some big cities are not in it, that you expect to be in it, but it's those cities that got hit the hardest in 1918 are part of this surveillance system. So you see there are plenty of cities in New Jersey that make, Newark is on, this city is on it, Elizabeth is in, Camden, I think. There's a bunch of cities in New Jersey that are reported every week. So just take a peek at it. It's always interesting. And so if we look at the burden in the U.S. in the average year, there's an estimate approximately 50 to 60 million infections, accounts for about 25 million physician visits, is responsible for up to 800,000 hospitalizations. And deaths can range anywhere from about 3,400 to almost 50,000 a year. And the average is about 23,000 deaths per year, 23.6, and which comes out to about 9.0 per 100,000 residents, with a range from 1.4 to 16.7, which actually makes it one of the leading causes of death in the United States. So if you look like estimates of death associated with seasonal flu from 1976 to 2007, if we look at age-specific estimates, for those under 19 years of age, the estimated average is about 124 deaths a year, with a range from about 57 to 197, at least between these years, a rate of about 0.2 deaths per 100,000. 19 to 64 ranges in the middle, a range about 1.5. But look at over 65. 66.1 per 100,000. The secondary to flu. So that's where it's really 90% of influenza-associated mortality takes place in people over 65 years of age. And for the reasons of the exacerbation of the underlying condition. But the mortality is really an issue for 65 and above. The epiforce behind driving the flu is in our youngest citizens, and the oldest citizens are paying the ultimate price for their children. So it's like revenge of the child, right, or something. This is the latest data from the CDC of this season. This, obviously, these are the past seasons, ranging back to 2009, 2010. And you see that you have most of the seasons peak earlier in the year. This hasn't peaked yet. This is this year. So you can see this is as of week 10, which I think was 2 weeks ago. This is the latest data you could find. So flu is actually going up. And I don't know about here, but we're seeing a lot of it at St. Pete's. I don't know if you, there's a lot of kids coming in with influenza. So it's really beginning to take off now. And then if we look, so influenza positive tests reported to CDC. So what happens is these centers that are asked to send in specimens, respiratory specimens, and then they test for flu. Right? Because, again, most ILI is not flu. It's other respiratory viruses. But if you look at this, you'll see, too, here, that it's continuing to increase. There's a little drop-off as of the 10th. However, essentially, the isolate numbers are increasing. And the most positive is influenza A, is the dominant strain. This is influenza B. Both are rising, but it's influenza A that seems to be the dominant strain. You can see this is the intervals that they accept. This is more considered greater, going over the interval that's acceptable. And you can see we did spike, not quite like the last years. Those are epidemic thresholds, this upper limit. And we're spiking again now, but slightly. But you can see so far the year isn't as bad as past years, but we are increasing as I speak, so it's meant to be seen by the end of the year. And then as a pediatrician, when I last was here, it seemed to not be affecting, at least in terms of mortality. There were only 11 reported pediatric deaths a month ago. Now there are 28. So it's more than doubled in the time since I last was here. I think it was exactly a month ago. Pediatric deaths. And again, deaths overall, you could see, are less than they had been in past years. But we're not finished with this year, so it's meant to be seen. This was the map of flu when I was here the last time. And you can see for most of the country, it was local transmission, local spread, with some regional, and a few states with widespread. This is the latest map. Right? So you can see it's increased markedly in the 1 month. I spread flu throughout. It spread markedly throughout not only the continental, but Alaska, the United States, which is why probably Sarah Palin hasn't showed up recently.
So
Thank God.
the A and B, do they break it down by region?
No, I think they do. And last time, and I didn't do it this time, and I apologize, I actually had the New Jersey sheet. So you could actually go on, if you go on FluView, you can break it down by state. I didn't get it this time, but if you're interested, it's easy, and you can go down. And New Jersey puts a lot of information of what's going on in the state, and you can find any state. Excuse me. So quickly, the virology. It's an orthomyxoviridae virus, which is a segmented RNA virus. There's 3 distinct types: influenza A, which can cause pandemics and epidemics. Influenza B can cause widespread flu, but not usually epidemics or pandemics. And influenza C, which is its little brother or sister that doesn't do much. It causes a mild upper respiratory tract disease, and it's fairly well ignored. It's the ignored child of influenza. So it really doesn't cause much disease. When we look at the virus, it's a simple virus, but it's well designed. It's a, what was that? What they used to call that? Intelligent design. But it's a product of evolution. It's really designed for what it does. And it has 8 segmented RNA, which make, I think, 10 proteins. The proteins that are most important, which we'll talk about, is the hemagglutinin, which is known, you see it as H or HA, so the H1, H3 is referring to hemagglutinin, and the other is the neuraminidase, NA or N, which is in the N. So H1N1 is referring, that's how you identify that particular flu. And these are enveloped glycoproteins. The hemoglobin H or hemagglutinin is responsible for the viral attachment to host cells. So this is how the virus enters your cell, your respiratory cell. And it's cleaved by host cell proteases. Not by the viral proteases, but the host cell. So it requires the host to even become activated. Right? And you don't get sick if it can't enter the cell. So it's the hemagglutinin that's responsible for causing infection. There are 16 highly divergent, antigenetically distinct hemagglutinins in influenza A. H1 through 3, of course, epidemic and pandemic activity in man since we know, but probably way before 1900. And H1 through 16 are all found in our birds, our colleagues, the birds. So flu is really, it's sort of appropriate. Flu is really a bird disease that has come to mammals. So, but its host are avian species. So you'll find all forms of flu in avian species, but you find only a few in human. Anti-hemagglutinin antibody protects against infection and disease. So this, when you're getting your flu shot, that's what they're introducing, is the hemagglutinin. That's what's important. For you to make a response to that, and then hopefully in this coming season, when the flu shows up, it's close enough to what the flu is that it will protect you from infection. Okay? The neuraminidase cleaves the celiac acid from the viral and host cell membranes. This prevents virus-to-virus aggregation and prevents virus-host cell surface retention, and in fact allows the virus to escape the host cell into the bloodstream and then, or wherever, and then infect other cells, the progeny virus. There's 9 distinct neuraminidases, and 1 and 2 have been associated with epidemic and pandemic activity in man, and N1 through 9, not surprisingly, is found in birds. Anti-NA antibodies reduces efficient virus release from host cells, but does not prevent infection. It can cause decreased severity of illness or decrease viral shedding. These are what also Tamiflu, which we'll talk about in a moment, this is what they're aimed against, the neuraminidase. The antivirals are aimed against this target. Okay. So I said it's a remarkable engineered device, the flu virus. It really is. And what it does is it escapes immune detection. It's really quite amazing. And it has 2 strategies. One is called shift, and that's a major change, especially in the hemagglutinin, right? So now your body doesn't recognize it anymore. And this is generally caused by an exchange of gene segments. It occurs in A subtypes only. It does not occur in B, right? And these cause pandemics. This occurs infrequently. This is an average of about once every 33 years. So you expect about 3 pandemics per century. Drift is a minor change within a subtype. It, too, alters it enough to make protection less effective. It's a gradual accumulation of amino acid changes in the hemagglutinin or the neuraminidase. It can occur in A and B subtypes. These may cause an epidemic. These are called drifted. This happens continuously. So, in fact, you could start the season in October, and by April, you've drifted enough that the vaccine that you used in the beginning may not be as effective in the end. This happens all the time. So this is a virus that's constantly evolving to escape immune detection. And this is essentially just a representation of that, of what we call shift, where you might have a current circulating human strain. It meets up with an animal strain. Generally, it's in pigs, because pigs can usually their respiratory epithelium and their gut epithelium can usually has receptors that can accept both bird flu and human flu. Then the cells meet, they fall in love, and like humans, they exchange their genetic material. And if it's correct, if it works, what can happen is they can get the other proteins or the other segments are from human, and the hemagglutinin or the neuraminidase are from the bird, then they become novel, but it can be transmitted in humans, and then you get a pandemic strain. By the way, this is exactly how they make the flu virus also, when trying to alter the virus to be more congruent with the circulating viruses. This is the technology that they use. Just a word about avian flu. It usually doesn't infect humans, but human infection has occurred. Illness in humans ranges from mild disease to very severe disease, and so it's associated with contact with infected birds. And infected bird saliva, mucus, and feces. I always knew birds had feces. I never knew they had saliva, but I guess I shouldn't be surprised. Right? So that's how humans. And where do you usually see it? You often see it where there are large bird markets and birds, right? So often Hong Kong gets blamed, and there's markets in China, these very large chicken markets and bird markets. And if they get the flu and people are in close proximity, sometimes it jumps across. Person-to-person transmission of avian influenza is very rare because it's really not acclimated to humans. It can be limited, but it's inefficient and usually not sustained. And there are 3 types of avian influenza known to infect humans: the H5, the H7, and the H9 strains have their reported human infections with those. And as of January 15th, the USDA reports detection of highly pathogenic avian influenza H7N8 virus in commercial turkey flock in Du Bois County. And you say, why are you talking about it? Why is this important? It isn't. For one thing, it's very important to people in agriculture. This could wipe out, it has a great economic impact. In fact, there was concerns about Thanksgiving. There was some reports that, oh my God, it's going to wipe out the turkeys, and we'll have no Christmas and Thanksgiving turkey. But it's more than that. It could really decimate flocks all over the world. And the first detection of highly pathogenic avian influenza H7N8 was this is the first detection of this PAI in the United States. So it's sort of an unfortunate circumstance. There's also low pathogenic avian influenza H7N8 has been detected in the U.S. Now, unfortunately, low pathogenic viruses have been known to rapidly evolve into highly pathogenic viruses. So that's not good news. The low pathogenic viruses are usually asymptomatic, are called mild disease in birds. There's, I guess, a ruffled feather disease I wasn't aware of, or a drop in egg production. But the highly pathogenic viruses have high mortality rates and can wipe out entire flocks of birds. As of today, even as of today, there's no reports of avian influenza in humans in the United States this year. Just a quick history. Pandemics consistent with influenza described since the 16th century. The influenza virus, as I said in the beginning, was first isolated in 1933, and the development of the vaccine followed very quickly. And that was spurred by the military. And you could imagine why. After 1918, for instance, the German High Command blamed the loss of World War I on the flu. They said their troops were decimated by flu, that's why they lost. Of course, all the troops were decimated by flu, but you have to blame it on something. But the military was always very concerned with influenza and its effects on troops. The commercial vaccine was approved in the U.S. in 1945, so it's been with us for a while. And it got approved because we developed the technology to produce millions of doses annually, which you require, right? So we were able to grow large quantities of virus in eggs. One egg creates one vaccine dose. One egg, one dose. So when you went into an influenza factory, it was like from Matrix. Remember all those pods? It was just like that. You see millions of eggs where they're producing virus. Now what happened has a great effect on the agriculture because you have to order those eggs. Eggs don't grow on trees, right? They grow on birds. So the farmer, they have to make contracts before time on saying how many eggs are going to be diverted towards influenza vaccine. This is a big issue, right? They could, at that time, elucidate the physical properties of the virus and development of principles of chemical deactivation. So once they got that technology together, they can make flu vaccine, right? So in the 1970s, the advancement, they made a subviron or split virus preparation. That means you're not getting the entire flu virus, you're not getting a live virus, you're getting the hemagglutinin virus. You're getting the hemagglutinin glycoprotein. You can't get the flu from the flu vaccine because you're only getting the at least that's not the live attenuated. That's the flu shot. It's impossible to get the flu from the flu shot. Now you may have the flu incubating at the time you have the flu shot, and the flu shot's not going to stop that. But you can't get the flu. And how many people have heard people, I don't get the flu because I get the flu from the shot? Can't happen. And now all of it in the United States is subviron. There's a monovalent, bivalent, trivalent, quadrivalent, and pentavalent preparations. And that's been available since 1978. And the trivalent vaccines usually turn two A's, one H1, one H3, and a B virus. And in 2003, they approved the live attenuated influenza vaccine, known as LAIV. It mimics wild type, but it's very clever. It's manufactured, it's developed so that the virus can only reproduce at the temperature that's in your nostrils. So the virus can't move further down the respiratory tract. It only could do it at the nostrils, and it's attenuated. Now, there have been some examples of people getting that and then spreading it, but there's no, you.
Unfortunately, I've got to go to a meeting at the dental school.
Oh.
But if I can have just one moment, you showed the doughboys parading through the city in the summer of 1918.
Right.
That, in fact, was a major political, medical contretemps. It was known that the troops, and you showed them in the hospital in Kansas, traveling by railroad, the only way, obviously,
Right.
to the eastern ports of embarkation, and then to France and to the war, Belgium and so forth, would spread this to some degree.
Uh-huh.
There were warnings from people who were your counterpart a century ago that went up to Surgeon General level, and it's not clear that it went to cabinet level and did not go to the level of President Wilson. In spite of this very clear warning, they insist on bringing thousands, tens of thousands of troops from all the cities, the map of the United States, Boston going on down. The calamity was unspeakable. And there are descriptions of an entire block of people dying.
Right.
One right after the next. The burial arrangement was overwhelming for this, and it did not have to happen. In fact, the war ended 11/11/11.
Right.
Now 11th day, 11th month. It wasn't that far before. Talk about the politics. It was known the war was going to end at this point. There's no question on either side that the war was
No, especially when America entered
well,
the United States.
It was clear all over the world. It was
Right.
clear to the French, to the Germans, etc. It was a residual military activity. They really weren't needed any longer to speak of. Certainly not in that number. And by the way, there are newsreels showing able-bodied young men, 18, 19, 20, standing like this, going down, 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 one, dead.
Right.
Just like that with this. That's how virulent this was. You mentioned neurological. It's a disease called von Ecomono's disease.
Right.
Encephalitis lethargica. The movie Awakening is a latter-day representation of the prolonged neurological problem that some of them had. It's probably beyond the scope of this, and we'll go any further into this. But De Niro's first role was representing somebody who improved with L-Dopa and then relapsed with this. So the implications go far beyond that time. I myself had the post-65
Oh.
immunization.
Oh.
And I had tremendous swelling at the site. And I became ill with a low-grade fever, and I was ill. Whether I was incubating the flu anyway or not, or how this happened, not that many people actually got the megapotent vaccine, but I did. And my own internist told me that he has occasional people like me who became quite ill
Huh.
because of it. I don't know if there's any literature or anything on this. By the way, I've enjoyed this very much. I wish I could stay. But
Well, thank you very much for the other thing to add to that was
Just in one sentence, summarize that.
one sentence.
No, not everything. So the people online.
Now, Dr. Evans, just kindly a fascinating account of incidents of more in-depth discussion of the impact of the influenza virus during World War I, especially via the transmission via American troops and some of the sequelae and consequences. So thank you very much, Dr. Evans. We appreciate it. The other thing about that is some people now speculate that Woodrow Wilson had the flu and encephalopathy, which really deterred his activity at the Versailles Conference. And then his rest of his presidency, he was out of it.
it was in October of 1919. Versailles had ended, and he had a classic CPA.
Well, there's some new stuff. If you read Margaret Macmillan. But never mind. We could talk about that later. Okay. Moving ever forward. So we have now the live attenuated influenza virus. Okay. And this essentially goes over it. But again, the growth medium up until recently, again, has been chick embryos. So you acquire one egg, one dose of vaccine. So think about that. How difficult. And it's a bird disease. Right? So some of the viruses actually kill the chick embryos, making it almost impossible to cultivate particular strains of this particular virus. So there are a lot of complications. We went over most of this. Okay. Just for those who are clinicians, I'll quickly go over this. There have been numerous changes in the nomenclature of flu, which can make it very confusing if you're reading the literature. So those who are interested in reading the literature, just let me quickly go over it. We used to call it TIV, trivalent inactivated vaccine. It's now called IIV3, inactivated influenza vaccine, 3-valent. Okay, there's a standard in high dose. The high dose formulation is approved for people like me, 65 and above. It's a higher dose, and it's supposed to be more immunogenic in your older population. Then there's a CCIIV3, which is cell culture inactivated vaccine 3. And this is a new development that doesn't require the chick embryos. And this has a small amount of egg protein. You know, always the complaint for those who vaccinate people is, oh, I have an egg allergy, I can't get the flu vaccine. But it's not true. So now there is some that has a small amount of egg protein, and this is only approved for those 18 and greater. Then there's an RIV3, you'll see, which is a recombinant influenza vaccine. This has no egg protein. Unfortunately, it's expensive, and it's only approved for those 18 years of age and greater. Then there's an inactivated influenza vaccine 4-valent, IIV4, which includes 2 A's and 2 B's. There's an intramuscular and intradermal administration. The intradermal is supposed to be less painful and maybe more immunogenic. The intradermal, however, that's only approved for those 18 through 64. And then the live attenuated vaccine is now LIV4. It has the 2 A's and 2 B's. It's the same components that are in IIV4. Okay? So you see, they changed the terminology completely, and if you're reading about it so you don't get confused, you can keep this as a cheat sheet and see what they're talking about. You know, we like to change terminology because it keeps the layperson in a fog, right? It doesn't makes it difficult to understand. Therefore, we could charge them money because we sort of interpret it for them. This is what Pat asked. This is the 4 in the current vaccine. The 4 components. There's an A California 7 2009 H1N1 pandemic 09-like virus. There's the A Switzerland 97 whatever H3N2 virus. Then there's the B, and I don't know how to pronounce that word, but I can correctly, but I can't imagine why they would name it that. You'd think you could name it something else, well, unless they have a real good sense of humor. But I guess it's Fouquet. If it was Stephen Colbert, it would be the Fouquet virus. That's the B, and then the B Brisbane is the 4th. So if you get the IIV3, you're getting the A California, A Switzerland, B Fouquet. And if you get the IIV4, they're adding the B Brisbane.
So this year's A, which is...
matches the circulating strain.
Pretty well.
Yeah. In fact, all of them matched all the circulatings. This year, it's a very good match. You know.
Yes, the epidemic is taking off.
And it's taking off because, frankly, less than half the people, the CDC just put out, less than half people in the United States have gotten the vaccine.
And maybe if they got it early, it's waning.
It could be. There could be any number of reasons. But less than 50% of the population to this point has gotten the vaccine, which is a little disappointing. But, of course, who wants to get the Fouquet virus? How do they get this? How do they even establish this? Who makes it up? It takes about at least 6 months, 6 to 8 months, to produce large amounts of this virus to make enough vaccine. So you have to start, and since the season starts, at least in this part of the country, around October, you've got to start in the spring. But the circulating virus isn't here. So what do you do? How do you, it's a guessing, it's like, this is the ultimate, right, Atlantic City dice roll. Or probability. You know, it's very interesting. So how do they do this? Here for our new residents, this is a great job. You'll always work. Get higher than this. Right? Some manufacturers even roll the dice earlier. They make a guess and they start doing it earlier. However, there are 142 national influenza centers in 113 countries. This was established in 1948. They have year-round surveillance, and they study influenza disease trends. Then they send the viruses that they actually collect to 5 World Health Organization collaborating centers for reference and research in influenza. And they're located, one at the CDC in Atlanta, one in London at the National Institute for Medical Research, one in Melbourne, the Victoria Infectious Disease Reference Laboratory, in Tokyo, the National Institutes for Infectious Disease, and in Beijing, the National Institute for Viral Disease Control and Prevention. And they analyze the viruses. Then the WHO will recommend specific viruses for inclusion in the upcoming season. And they have 2 meetings, biannual meetings a year. One's held in February for the Northern Hemisphere, us, for the coming season, and one is held in September for the Southern Hemisphere. Okay? However, the final decision for each particular country is made by some regulatory agency in that country. And in the U.S., it's the FDA who makes the decision of what's going to be in the vaccine. Right? And what do they use? Again, surveillance data for circulating viruses. They forecast predictions for upcoming seasons. They have to have the availability of a good virus candidate, one that could be propagated, that they could develop. Some of them they can't. Then they're in trouble, right? It has to have the ability to grow and select pathogen-free chicken eggs or canine kidney cells. If it can't grow in those, doesn't matter. You can't make it. And then vaccine viruses must be tested and available in time to allow for full-scale production. So you can see this is a huge job. And it happens twice every year to prepare for it. And this just quickly is adjusted vaccine effectiveness. We're looking from 2005 to 2015. And what you see could range from as low as 10% effective in years where it's not matched, up to about 56 or 60% effective in years where there is a good match. And if we look at this year, we find that the overall vaccine effectiveness is about 60%. Right? For the H1N1 pandemic, it's about 51% effective. For all influenza B, it's about 76% effective. And for the B Yamagata lineage of the B virus, it's about 70 to 80% effective also. So it's pretty effective. The problem we're seeing is that most people haven't been immunized. Now, as of February 24th, 2010, we used to have, is there any clinicians? Okay. It used to, remember what a pain in the ass it was. Excuse me. What a pain in the arm. It was, every person who came in, you had to figure out that they meet the criteria for flu shot. It was really an effort. So in 2010, they said, to hell with it. Everybody over 6 months of age. Just give it to everybody. So the recommendation is everyone get it over 6 months of age. Okay. Special considerations, vaccination in children 6 months through 8 years of age. In those who have previously received at least 2 doses of quadrivalent vaccine need only 1 dose. If they haven't had that, they need 2 doses with an interval of at least 1 month. So if they're under 8, they need, and over 6 months, they need 2 doses if it's their naive year. For those who received less than 1, right, they need the 2 doses. Okay? So that's a special consideration in kids. Contraindications, all vaccines should be administered in settings in which personnel and equipment for rapid recognition and treatment of anaphylaxis are available. Contraindication is a severe allergic, this is the only one, severe allergic reaction to any component of the vaccine or to a previous dose of influenza vaccine, which is, of course, for all vaccines. And precautions, which means it's up to the judgment of the clinician, is moderate or severe acute illness with or without fever, and if you decide to defer, give it as quickly as possible once they recover. But of course, if there's a terrible a lot of flu going around, and even if they're moderately ill, you might want to give it then. Or if they've had a history of Guillain-Barré syndrome within 6 weeks of vaccine administration, generally do not give if not at high risk. That patient's not at high risk for complications. Okay. So what about egg allergies? Okay, history of an egg allergy, but they've only experienced hives after exposed. There's no contraindication to the vaccine. Okay, you can give IIV 3, R4, or RIV 3. In those over 18, no data on use of live attenuated virus. And then observe for at least 30 minutes for signs of reaction. If they have history of reactions to eggs, including angioedema, respiratory distress, lightheadedness, or recurrent emesis, or required epinephrine or another emergency medical intervention, give the RIV3 if they meet the criteria, in other words, over 18. And if RIV3 is not available or doesn't meet the criteria, in other words, they're under 18, then give the IIV inactivated by a physician with experience in the recognition and treatment of severe allergic reactions, and then observe for 30 minutes. These are the recommendations. And in suspicion of egg allergy, secondary to previous allergy testing, but no known exposures to eggs, again, if they meet the criteria, give the recombinant vaccine, and if that's not available, then consultation with a physician with expertise in management of allergic conditions should be obtained before vaccination, like Dr. Oleski, immunologist. Now, this is interesting. This is early and end-of-season flu vaccination coverage. This is what I was talking about in the United States. So these are different. This is all persons, children, and adults. This is the last 213, 214, 214, 215, and this year. And you can see early in the season, like November, it's about 40%. Late in the season, and in children, they do slightly better. And you can see even at the end of the season, which is not yet here, so this is last is 2014-15, we reached about 60% last year in children, who remember are the driving force behind it. This year, we're less than 50%. Okay, so that's maybe one reason. It might have mitigated somewhat, but it's another reason why we're seeing it take off. Impact of influenza in healthcare personnel. This is important. This is a huge public health debate going on now. And healthcare personnel are often involved in hospital-acquired influenza outbreaks, including here. I know Dr. Capilla wrote an article of an outbreak here in the 1980s, I think, where 9 patients died. And many healthcare personnel, we come in no matter what. On our deathbeds, we crawl in to take care of our patients because we're so devoted, even with the flu, which could be a very bad thing. The mean excess hospital costs associated with a case of hospital-acquired influenza, $7,500. The mortality is as high as 8%. Large-scale, it also causes large-scale absenteeism when they become too ill. during outbreaks, and that compromises patient safety, and improved healthcare personnel vaccination rates is associated with decreased hospital-acquired influenza in both acute and long-term care facilities. So why healthcare workers will not get the flu is hard to believe. However, I think the message may be getting through. Oh, this is just one study which looked at 2 long-term care facilities. This is a facility. This was mortality. With respect, and this is a group in a long-term care facility that didn't require vaccination. This is one that did require vaccination against flu, and you could see the marked difference in mortality rates in both institutions. And since 1986, Healthcare Control Practice Committee, or HCPAC, and the Advisory Committee on Immunization Practices recommends that all healthcare personnel receive annual influenza vaccination. And the Healthy People 2020 target of 90% of healthcare personnel receive annual influenza vaccination. And if you look at this year, which is this is in November, that's in April. We're not in April yet, we're close. But you can see it's been slightly higher this year than last year, and it's not bad. We're around 80%. So that's good. It used to be range around 40%. Now we're around 80%. So that's good. It worked in healthcare personnel. And if you look at it, physicians are the group most likely. There's about 87.5% immunization, where assistant aides are at the bottom, about 55%. But remember, flu doesn't care if you're the doctor. In fact, the doctor is the least one who comes into the room. It's the people who are in and out of the room all the time that really require it, because anybody in contact with patients, and of course patients have those conditions that are exacerbated by influenza infection. So the hospital should be the first place you get vaccinated. And this isn't, okay, and again, hospitals, about 84% of the healthcare workers in this survey were vaccinated. Other settings, it's much less. But it's an improvement. And this is very interesting. Where it's mandated, because this has been a huge argument in the healthcare field, whether we should have mandatory influenza vaccination for healthcare workers. It's a huge argument. But where it's mandated, you see the highest rates, not surprisingly, 87.2. Where it's recommended, it's a precipitous drop-off, only about 62%. And where the hospital doesn't seem to give a damn, it's about 40%. So it appears the mandates are effective in getting people, at least healthcare workers, vaccinated. This is just all the professional societies, just quickly for your viewing enjoyment, who recommend vaccine. Okay, no big. Okay, now just quickly, the anti-flu medications, they're neuraminidase inhibitors, the N word, right? Neuraminidase inhibitors. It's recommended for use in the U.S. by U.S. FDA during the 2015 to 2016. These are the antivirals that are recommended, not the amantines. It's the neuraminidase inhibitors. There are 3. The most famous is oseltamivir, also known as Tamiflu. It's oral. It's effective against influenza A and B. Treatment can be given at any age. Prophylaxis can be used in those at least 3 months of age. Its adverse events are nausea and vomiting. And there's some post-marketing reports include serious skin reactions and sporadic transient neuropsychiatric events, another self-injury and delirium. Those are most commonly seen in Asia. Then there's zanamivir, or Relenza. This is an inhalation device. It's much more difficult for young children. It, too, is effective against A and B. It's in those for treatment, at least. Okay, it's again effective against A and B. It's in treatment in those over 18 or above, not recommended for prophylaxis. Its adverse reactions are diarrhea, and post-marketing reports include serious skin infections and also transient neuropsychiatric events. The recommendations for antiviral treatment: do it as early as possible. They talk about within 48 hours. You can give it, that's when it's most effective. However, you can give it in those more seriously ill after it. Give it in hospitalized patients, patients with severe complicated or progressive disease, and patients at higher risk of complications. And who are those patients? Those children under 2 years of age. 2 or under, give it. Adults over 65 or above. Persons with immunosuppression, including that caused by medications or by HIV. Pregnant women or those within 2 weeks of delivery. Persons less than 19 years of age and receiving long-term aspirin therapy. American Indians and Alaskan Natives, I'm sure the disease is more severe there, but that's the recommendation. The morbidly obese, and residents of nursing homes and other chronic care facilities. So if they're hospitalized, you just give it. Those with, who are the high risk factors are those with the following conditions: chronic pulmonary conditions, including asthma, cardiopulmonary conditions, except isolated hypertension, renal, hepatic, and hematologic, including sickle cell disease conditions, metabolic conditions, including diabetes, neurologic and neurodevelopmental conditions, disorders of the brain, spinal cord, peripheral nerves, and muscle, which include cerebral palsy, epilepsy, stroke, intellectual disability, moderate to severe developmental delay, muscular dystrophy, and spinal cord injury. And this is a great statement. Essentially wraps up everything I said. There's nothing more predictable about flu than its unpredictability. This is still really one of the major public health problems because it's just very hard to know what's going to happen. And, I just wanted to mention the New Jersey Immunization Network. We work on flu vaccinations. We work on flu. It's open to all. And if those who are interested, contact Michael Sester at these numbers. If you want to be a member of this wonderful organization, I recommend you guys be in it as residents, because there's opportunities to do things. It's a terrific organization, which I also happen to be president of now. Okay. So thank you for bearing with me. That's it. That was a lot to cover. And I'd be happy to entertain any comments or, yes.
Here I am, hopefully an educated person. And every year I get my flu shot. But I have no idea what flu shot I'm getting. I just roll up my sleeve and go to the front of the line and give me a flu shot. Now, can I trust that the New Jersey Medical School, UMD, and University Hospital is selecting the right vaccine for me?
No.
Repeat the questions.
Oh, the question was by Dr. Oleski, a young man, but he wonders that he gets a shot here through Employee Health Services, who offer to all workers, and he's wondering, are they giving him the proper shot? He just rolls up his sleeve and gets the shot. And my recommendation is ask. That's what I did in my hospital. I asked, do you have the for 65 and above? And they go, yeah. Well, I'd like to request that. My youthful appearance, they never think I'm 65. So I request, do you have it? And they say yes. At least where I work, they said yes. And then they gave it to me. I think if you get in a line in the cafeteria, they're probably not. It'll probably give you the IIV-3.
Is that what in common parlance they're referring to as the high dose?
The high dose is an IIV-3, but you almost have to ask for it because I think it's more expensive.
For people who are leaving, fill out the forms, and you can put them on the table out there. Thank you.
Yes.
Is there any benefit to receiving the quadrivalent versus the trivalent? Do you find that the second B strain is present or not?
Is there a advantage to getting the quadrivalent versus the trivalent? Yes. Because like the last slide said, there's nothing more unpredictable than flu. So it doesn't take away from the immunogenicity of any of the other strains, and it broadens your coverage. So, yeah, if you can get the 4, get the 4. Unfortunately, the high dose doesn't have a 4. So for us, 65 and above, we're not able. We could get it, but I think for me, the high dose trumped the 4. But you are clearly not 65. Not yet. We're hoping you all get, yeah.
Peter, why is the disease, why is influenza seasonal, and why this year has it not yet peaked when it usually has by now in other years?
Well, the question is, why is influenza seasonal, and why hasn't it peaked this year as it has in other years? Well, the second part, if I could answer that accurately, I'd probably be on my way to Sweden to collect my Nobel Prize. That's not good. Each year is different. I think it depends on susceptibilities. It depends on the closeness of the strain to past strains. In the beginning of this flu season, you saw mostly younger people getting the flu. And that's because it may have been very much more, this H1N1 is probably familiar to a flu from the 1970s. So the person living, like me and you, in the 1970s was probably exposed to it and have some kind of immunogenicity against it. I'm sorry, in the first part.
Well, why is it seasonal?
Oh, why is it seasonal? Flu is best transmitted, most efficiently transmitted in cold, humidless weather, which is much more like the winter than is the summer. And in the winter, there's a lot more social contact. People spend indoors. If it's cold, they keep the windows closed. So since it's a respiratory transmission, since you're in a closed space, you're more likely to transmit it. It does transmit during the summer. It's not as efficient. You probably get lower doses, and people don't test for it in the summer. Feels like we can go into the whole thing about testing, but when a disease is much less prevalent, the studies that you do, no matter what the sensitivity or specificity, you're more likely to get a false positive. So people don't test for flu in the summer, but certainly it is transmitted at that time, but not as quickly, not as efficiently, and so you don't see the large groups. Now, interestingly enough, when it's new pandemic strains, that often is transmitted later in the year. So you often see it in the spring. If you remember in 2009, the outbreak really started in April and May with the new H1N1.
So, it's hard to kind of wrap your head around the notion that healthcare providers don't get vaccinated.
Right.
And that it can't be required. It's also not one of the required vaccinations for school children. Am I correct?
Well, New Jersey, it is required for daycare attendants.
Yeah, but school age. So how much of the resistance to it is the poor match between the vaccine and the,
Well, I think the thing.
strain and the cost? I mean, how much of it is really a dollar and cents issue, that there isn't a stronger requirement for kids to get vaccinated with the prevailing, whatever the prevailing strain that's believed to be circulating, and that healthcare providers want, and teachers, and why are we not more aggressive in pushing vaccination?
Well, I think there is probably, the vaccines. Wow, that was a big one. I should give it. No, Pat's excellent question was about why we, some healthcare providers may be somewhat hesitant to give the vaccine. Is it a dollars and cents issue? Is it an effectiveness issue? And right? I mean, essentially, that's what you're asking.
There's a lot of elements.
And there's a lot of elements, right? And why the healthcare workers? Well, I'll tell you, as a group, healthcare workers have the most distorted view of flu that I've ever seen. Because when we started here, when we really started campaigns, I was working with Beverly Collins, if you guys remember Beverly, Infection Control, in trying to get people vaccinated, and there was so much resistance. And the healthcare workers, including doctors, had the exact same misconceptions as the general. I've heard things that are unbelievable. Like, oh, I got it, and I got the flu from the shot. Well, you didn't. Unless it's like a resurrection virus or something that can...
I had a pulmonologist, my pulmonologist,
Yeah.
who asked me if I had my flu vaccine, and I said, yes, did you have yours? Oh, I never get the flu vaccine. And I said, I will never come here again.
Good for you.
You're an idiot. I'm sorry.
Pat just said her pulmonologist is an idiot. No. The other excuse I heard that I just love is, well, I never got the flu before. I said, do you know how many people with heart attacks say that? I never had a heart attack before. That's right. There's always a first one. And maybe you can survive. Well, why don't you stand on those train tracks? You've never been hit by a train before.
Well, I guess the thing that's so unbelievable is that it can move so quickly. And
Right.
if you had the emergence of a highly virulent strain,
That's
it
right.
would get out of control before you could get people...
Absolutely. And what you brought up before he left, and he talked...
Did you shut it off? I was going to... Chris, I just wanted to say, we're going to continue talking. Chris is going to turn off the live streaming, but I wanted to thank Dr. Wenger.
Oh, my pleasure.
And we'll have to have you back for a debate because...
Oh, okay.
Anyway, thanks to the online audience. If anybody has questions, you can email
Tough,
me,
no.
Pauline.thomas@rutgers.edu, and I will extract answers from Dr. Wenger. And everybody, please fill out 2 forms, Dr. Oleski included. They're on the table out there. And they're on the table out there. There's 2 forms.